Welcome back to Neurovascular Nuggets, everyone. Today, Salma and I are diving deep into a fascinating and really critical paper that shines a light on an often underestimated complication of cerebral venous sinus thrombosis, or CVT, intracranial hypertension, IH. It's a condition that can have really serious consequences if not identified early.
Thanks, Professor. I'm really looking forward to this. CVT itself can be quite challenging to diagnose, and then to think about complications like IH on top of it, it just adds another layer of complexity. What was the main takeaway from the study that really jumped out at you?
Well, Salma, the headline really is quite stark. The study found that a significant percentage, 46% to be exact, of patients with acute CVT showed clear evidence of intracranial hypertension. That's nearly half, and they based this on concrete markers like elevated CSF pressure, papilledema, or optic disc protrusion. It's not just a hunch, these are clinical findings.
Wow, 46% is a huge number. I mean, when we talk about CVT, a lot of the focus is on anticoagulation and preventing pulmonary embolism or recurrence. But this suggests the IH should be right up there in our minds. What makes some CVT patients more susceptible to IH than others?
That's precisely what this paper aimed to uncover, and they found some really strong associations. Essentially, it boils down to the how much and where of the thrombus. They found that IH was significantly associated with higher thrombus volume, meaning the bigger the clot, the higher the risk. And it wasn't just size, the location mattered a lot too.
So, how much and where? Can you elaborate on the where part? Which locations were particularly problematic for increasing IH risk?
Absolutely. The study highlighted a few critical areas. Firstly, thrombosis of the dominant transverse sinus was a major player. This is a big one because the dominant transverse sinus is often the primary drainage pathway for a significant part of the brain. If that's blocked, pressure builds up quickly. Secondly, superior sagittal sinus or SSS thrombosis, either alone or combined with transverse sinus involvement, also significantly increased the risk. And interestingly, they also noted more thrombosed segments when bilateral transverse sinus thrombosis was absent, suggesting that if one side is severely affected, it's enough to cause trouble.
Well, that makes so much sense. It's like a traffic jam in the brain's drainage system. If the main highway, say the dominant transverse sinus, is completely blocked, everything behind it backs up. And what about the thrombus volume you mentioned? Was there a specific threshold where the risk dramatically increased?
Yes, they found a very clear correlation there. Thrombus volume actually had the strongest association with elevated CSF pressure on linear regression. This indicates a direct, dose-dependent relationship. More specifically, thrombus volumes over 4 milliliters were associated with a significantly higher risk of developing IH. That 4 milliliter mark is a really tangible number for clinicians to consider.
4 milliliters, that's incredibly precise. So, combining that, if a patient comes in with CVT and on imaging we see a clot larger than 4 milliliters, especially in the dominant transverse sinus or SSS, we should be raising a red flag for IH. Is that the gist of it?
You've absolutely hit the nail on the head, Salma. The dominant transverse sinus thrombosis, in fact, was identified as the most influential predictor of IH based on their multivariate analysis. This means even when accounting for other factors, its impact stood out. So yes, imaging is key here. It provides those crucial markers.
That's really powerful because imaging is something we do routinely for CVT diagnosis anyway. So, we're essentially getting more predictive power from existing diagnostic tools. Were these findings completely novel or did they confirm existing suspicions?
That's a great question. The study definitely built upon existing knowledge. Some previous studies had already hinted at associations between dominant transverse sinus thrombosis and IH, so that part isn't entirely new, but this study provided more robust evidence. However, what is novel, and this is where the paper truly breaks new ground, is the emphasis on thrombus volume and the extensive involvement of the superior sagittal sinus. These specific quantitative and qualitative markers hadn't been highlighted with such clarity before.
So, we're not just confirming, we're also discovering new important factors. That's the beauty of good research, isn't it? So, knowing all this, what are the practical implications for us in the clinic? How should these findings change how we manage or monitor CVT patients?
This is where the rubber meets the road. The implications are significant for clinical practice. Essentially, patients who present with these high-risk features, a large thrombus volume, especially over 4 milliliters, and thrombosis in strategic venous segments like the SSS or the dominant transverse sinus, may benefit from much closer monitoring and a more thorough evaluation for IH right after a CVT diagnosis. We're talking about potentially preventing serious, irreversible complications.
Irreversible complications, are we talking about things like permanent vision loss?
Precisely. Untreated or poorly managed IH can lead to papilledema, optic nerve damage, and ultimately permanent vision loss. Early identification of IH allows for timely interventions, whether it's optimizing anticoagulation, considering therapeutic lumbar punctures, or even shunt placement in very severe refractory cases. The goal is to preserve neurological function and critically vision.
That's a powerful motivator. So it's about being proactive rather than reactive. Instead of waiting for a patient to complain of severe headaches or visual changes, we can look at the imaging and say, okay, this patient is at high risk. Let's monitor them closely and consider intervention sooner. That's a huge shift potentially.
Exactly. It moves us towards a more personalized and risk-stratified approach to CVT management. Instead of a one-size-fits-all, we're now armed with data that can help us tailor our vigilance. It's about optimizing patient outcomes and preventing devastating long-term disabilities.
This is truly exciting. It feels like we're getting closer to precision medicine in neurovascular care. But you mentioned that some of the findings, particularly on thrombus volume, are new and require further confirmation. What does that mean for future research?
It means this study has opened up some promising avenues. While the findings are robust within this cohort, replicating them in larger, multi-center studies would solidify their generalizability. We'd want to see if these specific thresholds for thrombus volume, for instance, hold true across diverse patient populations and different imaging protocols. Further research could also explore the best methods for volumetric measurement and how it can be integrated into routine clinical workflows.
So it's a strong foundation, but we need more bricks in the wall, so to speak. This is incredibly insightful, Professor. For our listeners, what would be the single most important message you'd want them to take away from today's discussion on this neurovascular nugget?
I'd say this. While cerebral venous sinus thrombosis is a complex condition, this study has given us clearer, more objective imaging markers to predict the risk of intracranial hypertension. Pay close attention to thrombus volume, specifically that 4 milliliter mark, and the involvement of critical venous segments like the dominant transverse sinus and the superior sagittal sinus. Recognizing these high-risk features early can really make a difference in preventing long-term complications, particularly vision loss. It's about being vigilant and using the imaging data we already have to its fullest potential.
Fantastic summary, Professor. It really highlights how much impact targeted research can have on patient care. Thank you for breaking down these complex findings for us today.
My pleasure, Salma, and thank you everyone for tuning in to Neurovascular Nuggets. We hope this has been enlightening and helps you in your clinical practice or deepens your understanding. We'll catch you next time with another insightful discussion.